When I enter the patient's room, I will first want to perform hand hygiene. I want to make sure I wash my hands for a minimum of 20 seconds with soap and water. Then I will pat dry with paper towels starting at the tips and moving up. I will then go to the patient, draw the curtain in order to provide privacy for the patient during the exam. Good morning, my name is Eva and I'm going to be your nurse today. May I please have your name and your date of birth? And Mr. Patient, do you know where you are today? Now would you please hold my hand and just squeeze it gently? Thank you very much. I have determined that my patient is alert, awake, and oriented ×3. I'm grading him a 15 on the Glasgow Coma Scale because his eyes open spontaneously, the answers to my questions are appropriate, and he's able to follow motor commands correctly. Mr. Patient, do you have any allergies? How about any medical history or conditions I should be aware of? Do you currently take any medication? That could be prescription, over-the-counter, or herbal remedies? No? Very good. Chief complaint, seizure. Mr. Patient, why have you come to see us today? You experienced a seizure? When did this happen? Was the event witnessed? And if yes, how long was it in duration? Did you experience any head trauma or loss of consciousness? Did you lose bowel or bladder continence? Have you ever had seizures before? Do you have a history of epilepsy? And if yes, are you currently taking any medication for the condition? No? Thank you very much. Assessing vital signs, starting with pain. Mr. Patient, are you currently experiencing any pain or discomfort before we start your exam? No? Very good. Okay, let's start with your vital signs. I will first measure temperature, which I will do orally by placing the thermometer under the patient's tongue. My result should be anywhere between 96.4 and 99.1. I will then measure the patient's respiratory and heart rate. I'm going to place one hand on the radial pulse and my other hand on the patient's shoulder. I will first measure respiratory rate to go undetected. I will watch for the rise and fall of the chest for 30 seconds, then double that number, and I should expect a respiratory rate of 12 to 20 respirations per minute. I will palpate for the radial pulse. As long as the pulse is regular, I'll measure for 30 seconds ×2, and we'll expect 60 to 100 beats per minute. I will also want to measure the patient's oxygen saturation by placing the pulse oximeter on the patient's fingertip, and then the results should be 95 degrees oxygen saturation at room air. The final vital sign that I will do is the blood pressure, which I will use the two-step approach. I will put the cuff on the patient's arm about 1 inch above the antecubital fossa. I will want to make sure that there's about 2 fingers worth of space between the cuff and the arm. I will then place my fingers on the radial pulse, and I will start to inflate the cuff by pressing on the bulb of the sphygmomanometer. I will keep pressing until I no longer feel a pulse. Then I will note the value on the gauge and will quickly deflate the cuff so it's completely flat. Once the cuff is deflated, I will let the arm rest for about a minute. Then I will place the diaphragm of my stethoscope on the patient's brachial artery and will start to reinflate the cuff by pressing on the bulb, and I want to go about 20 or 30 points above my previous figure. Once I get to that value, I will slowly deflate the cuff by turning the dial on the bulb. The first sound I hear is the systolic rate. Second sound is the diastolic. I will want the value to be under 120/80, down to about 90/60. I will now want to assess for the general circulation of the patient. I will want to note the condition and the color of the skin, which should be congruent with the patient's ethnicity. We will want to check for capillary refill by pressing on the tip of the finger until it blanches. Then I will release it, and I expect for the color to return within 2 seconds. Testing the temperature of the skin, I will put the back of my hand up against the arm. The skin should feel dry and warm to the touch. Assessing for pulses at different sites. Pulses are rated at a scale of 0 to 3. A pulse of 0 is no pulse, and that has to be verified via Doppler. A pulse of 1 is one that's detectable but very weak. Pulse of 2 is regular, and pulse of 3 is bounding. To assess for pulse, we can start with the temporal area. We can do carotid pulse. When we do carotid pulse, we want to make sure we only palpate one side at a time. If you do both, you could occlude oxygen to go to the patient's brain, so that's dangerous. To feel for apical pulse, you want to go medial clavicular down to the 5th intercostal space. Put this stethoscope here on the left side of the chest, and hear the pulse. Brachial pulse is at the medial aspect of the arm by the elbow in this area. Radial pulse is by the hand, by the wrist, on the thumb side of the wrist. For femoral pulse, we want to be in the little groove between the patient's groin and leg. To feel for popliteal pulse, we want to put both hands behind the patient's knee. This pulse is a little bit harder to detect. For posterior tibial pulse, we want to go on the medial aspect of the foot, behind the malleolus in the area here. And finally, pedal pulse is between the big toe and the second toe, right in the middle here. To test for thyroid gland using posterior approach, I want to first give the patient a glass of water. I will come behind them, and I want to let the patient know what I'm doing so they're not startled. I'm going to reach my hands in the front by each side of the trachea. If I want to palpate for the right side, I will gently push the trachea and dislocate it slightly to the right with my left hand. Then I will have the patient take a sip of water. As they're swallowing, I will palpate the thyroid with my right hand. I really shouldn't feel anything, and if I do feel anything, it should be a very mild movement, like a sheet of paper underneath the skin. I will note that the right thyroid is larger than the left, and that is a normal finding. Assessing for lymph nodes. Lymph nodes should be soft, rubbery, non-tender, and movable. To palpate for lymph nodes, I'm going to first start at the preauricular area in front of the ear, postauricular behind the ear, occipital area at the base of the skull by the hairline, submental under the chin, submandibular, jugular, digastric, right underneath the little groove below the ear. The superior cervical is located in the area here. The deep cervical chain runs just along the area here around the throat. The posterior cervical is right behind here in this area. The supraclavicular nodes can be found here in the groove. It's easier for the patient to roll in their chest, so it's easier to palpate. Axillary is underneath the armpit. Epitrochlear nodes are found on the medial aspect of the arm, right above the crease of the elbow. And finally, inguinal nodes are right here, once again in the groove, between the groin and the leg. Assessing cranial nerves. Cranial nerve 1 olfactory, which is a sensory nerve. We're going to do the sense of smell test. I will first have the patient occlude one nostril, inhale, exhale. Same thing on the other side. I will then bring the scent bottle by the patient's nose, and as they're closing one nostril, I will have them inhale, and they will identify the smell. Cranial nerve 2 is the optic nerve, also sensory. We're going to do the Snellen test. Snellen chart is here. Patient is about 20 feet away on the other side of the room. I will have the patient read the lowest line that they're able to read at their location, checking the results. A vision 20/20 is average. If a patient has 20/15, then that's above average. It means that a patient is able to see an object 20 feet away versus a regular person who has to be at 15 feet to see the same distance. Cranial nerves 3, 4, and 6. We've got oculomotor, trochlear, and abducens. These are motor nerves. We're going to use the Perla test for this. Perla tests are pupils are equal and round and reactive to light and accommodation. We want to be in a dim room to do this test. We're going to have the patient look at a distant object in the room so the pupils will dilate. I will then grab my pen light. I will bring it in towards the left eye slowly. As the light approaches the pupil, I should have direct constriction on this eye. I will repeat the same movement. Now I will look at the right eye, and here I should see consensual constriction. I will repeat the same thing on this side of the face. To test for accommodation, I will once again have the patient look at a distant object on the other side of the room. Once the pupils are dilated, I will then stand in front of the patient with the pen And as the pen is moving closer to the patient's face, I will once again expect the pupils to constrict. For nerve number 5, which is trigeminal, that is a sensory and motor nerve. We're going to use the cotton wisp test. I'm going to have a probe with a little cotton tip on the end. I'm going to lightly brush it on the patient's face, above the brow, on the cheek, on the chin, and while the patient's eyes are closed, they should be able to point to the area of sensation as I'm touching their face. Their eyes are closed, and I will repeat the same on each side of the face. For the facial nerve number 7, which is sensory and motor, we're going to perform the taste test on the anterior 2/3 of the tongue. This cotton tip will have some sort of flavor on it. I will then place it on the tip of the tongue, and the patient should be able to identify the flavor. Cranial nerve number 8, which is acoustic, that is the sensory nerve. We're going to use a fork, a sound fork. I'm going to hold the fork by the stem. We're going to activate the two prongs by hitting them against each other. I will place the fork in the middle of the forehead. A normal finding would be for the patient to hear equal sound on both sides of the head. For cranial nerves 9 and 10, glossopharyngeal and vagus nerves, those are motor and sensory as well. We're going to perform the taste test on the posterior 1/3 of the tongue. This tip will be flavored once again. We're going to wipe it on the patient's tongue, and they should be able to identify the flavor on the Q-tip. The spinal nerve 11, which is the accessory spinal accessory nerve, that is a motor nerve. We're going to complete the shoulder shrug. Patient will be standing. They're going to shrug their shoulders. They're going to look to their left, look to their right. I'm going to then place my hands on their shoulders and have them shrug once again. Place the back of my hand to the right, have them turn. Same thing on the other side. Patient should be able to shrug and move their hands against the pressure of my hands without an issue. The final nerve is the hypoglossal nerve number 12. That's also a motor nerve. We're going to do the tongue to cheek test. We're going to have the patient push their tongue up against the cheek like this. I will then push my finger up against the tongue, and the patient should be able to resist the force of my finger. Cerebellar functions. We're going to do a general gait test. Patient will walk 20 feet to the side of the room and walk back. They should be able to generally walk in a straight line without swaying or losing balance. For the Romberg test, I'm going to want to stay close to the patient in case they lose balance or to prevent falls. But the patient will stand in a straight position like this with their arms down. They will then close their eyes. A regular finding is that the patient is able to stand still, possibly sway a little bit, but they should definitely not be able to step out of place. For the kinesthesia test, I'm going to take the patient's arm. Finger pushed down means down, finger pushed up is up. Then I will have the patient close their eyes. I will make the same motions with the fingers, either going up or down, and the patient should be able to identify which direction I went with the fingers. For the stereognosis test, I'm going to place a common object into the palm of the patient's hand, such as a paper clip or a binder clip like this. Then they will close the grip of their hand, enclose the object, palpate it. They should be able to tell me what the object is that I placed in their hand. And finally, for the graphesthesia test, I'm going to take a probe, a sharp probe, and either draw a number or a letter in the palm of the patient's hand, and they should be able to identify the character that I wrote inside their palm. Now finally, to assess the deep tendon reflexes, we're going to use the reflex hammer. First, for the brachioradialis tendon, I'm going to once again grab the patient's arm, medial aspect right here. I'm going to use the sharp part of the hammer to hit the reflex here, and I'm going to expect a, what am I going to expect? No, I forgot. Anyway, okay. Moving on. For the tricep, I'm going to have the patient's arm in this position, and I'm going to hit the arm with the sharp part of the hammer here, and I'll expect an extension on the arm. For the bicep, I'm going to find the bicep tendon, which is here, place my thumb over the area. Once again, use the sharp side of the hammer to hit my thumb, and I'll expect a contraction with the arm. For the patellar reflex, we want to have the patient sitting with their feet dangling. I will want to use the wide part of the hammer to hit right underneath the patella right here. When I hit this area, the leg should extend. Then I will do the Achilles tendon. The foot is usually in this position, bent. I will hit with, again, the broad side of the hammer right above the heel here. I will expect a plantar flexion, which is pointy feet, pointy toes, just like this, like a little ballerina. Last tendon is the plantar of Babinski. I will use the sharp pointy end of the hammer on the lateral side of the foot to do a reverse J. And the expected finding for an adult is for the foot to either stay the same with the toes or a slight curling of the foot. On a child, the expected finding would be a fanning of the toes. And thank you very much.